language. Thank you. And we're going to go ahead and introduce our ECHO team. Our elder resident, Fred Desjardins, just did a blessing and introduced himself. And so, Michelle, could you please introduce yourself?
Yeah, hi everybody. I'm Michelle Corcoran. I'm the nurse manager for the MAT MOUD program here at NACC.
Okay, and Tina?
Hi, I'm Tina. I'm the harm reduction supervisor here at NACC.
Lindsay?
I am Lindsay Kinkuni. I'm the community and tribal engagement specialist here at NACC.
And then I'm Kari Rabi. I'm a family practice and addiction medicine physician at NACC, and I prescribe buprenorphine. Okay, we can start the slides. Okay, so again, this is the Midwest Tribal Echo. Welcome. Today we have with us Sarah Jane Keaveny and Judy Rosenberger to talk about disease intervention services. Next slide. Just to let you know a little bit about us, we're the Native American Community Clinic. We're on Franklin Avenue in South Minneapolis. At the Native American Community Clinic, we offer primary care. We offer Suboxone or MOUD services. We do infectious disease intervention and treatment. We provide social service support. We have a dental clinic, a behavioral health clinic. We have an intensive outpatient treatment program. We offer elder care and traditional healing services, health promotion and maintenance program, and harm reduction services. And we have a pretty active outreach program. We are established in 2003, and we try to remain very connected to our community and tuned into what their needs are. So I'm going to turn it over to Lindsay.
So just some session guidelines for today. No protected health information, of course. We ask that you mute yourself when you're not talking. You're always welcome to eat your lunch during this. And then we invite you to use the chat. Please use the chat if you want to ask any questions or have any comments. Some announcements. So our next ECHO session will be November 16th, and that's with Simone Megas Harmison from here at NACC. And she's going to be talking about crisis de-escalation. And then on December 7th, we have Kaz Nelson from the University of Minnesota Medical School, and she's going to be talking about borderline personality disorder and treatment. This is just a list of a few other echoes that we recommend. So Indian Country Echo, Stratus Health, Hennepin Healthcare, they all cover topics such as opioid use disorder and harm reduction services, among many others. So let us know if you want any more information. You can let us know in the chat. Continuing education, we do offer that. We just ask that you complete the survey, which I'll email out after this session to receive the CE credits. And then finally, case presentations. We always welcome and encourage you to share those. It's a great way for us to all learn from each other's experiences. So let me know or email me if you have something to share. And then with that, I will hand it over to Sarah, Jane, and Judy.
All right, I think I have the screen right. Let's see. I don't see the, oh, there we go. Hello. Let's see, we'll go back here. My name is Judy Rosenberger, and I am a disease intervention specialist. I work with Hennepin County Public Health, and I'm based out of the Red Door Clinic.
And I can introduce myself. My name is Sarah Jane Keaveny. I use she, her pronouns. I'm a staff nurse with Hennepin County Public Health. I work in connection with the disease intervention team out of the public health clinic, and then am embedded with Hennepin County Healthcare for the homeless. And my role has been mostly in outbreak response and in the unsheltered community in South Minneapolis. And I'm happy to be here today.
Yes, thank you so much for having us here. This is exciting to be a part of this meeting. I have our slides started here. So this is kind of an overview of what we will be talking about today is the DIS program, which I'll explain shortly here. And then it's often called the HIV outbreak, but we like to acknowledge that it's really a drug-related infectious disease outbreak. There's other infectious disease involved. So at Hennepin County, we refer to that as DRID, the DRID response. And we'll be talking through the DIS program, talking a little about HIV, Hep C, and syphilis trends, our response at Hennepin County, and then some steps that we are taking, steps about relationship-based care with our patients. Let's see. All right. What is a DIS? Some people have no idea. Some people are really familiar with it. So I thought I'd just do a little background on what we are. It stands for Disease Intervention Specialists, and we work with people who have tested positive for HIV, syphilis, gonorrhea, and chlamydia. But right now it's more focused on HIV and syphilis, since there's just so much of that going on right now. It's a program that's a national program funded by the CDC and trickled down to the states, and then the states distribute the funds to different programs. And here in Minnesota, there's a group of DIS that work for MDH. There's about 5 of them. And then there's a group that work for Hennepin County, and we also have 5. 2 are based at the Red Door Clinic, and 3 of us are more out and about working on the DRID response. There's also a DI now at NACC, Paige is there, and there is one over at Clinic 555, which is the Ramsey County Public Health Clinic. There are also there's going to be 3 tribal DIs, I believe at Leech Lake, and then 2 other reservations where they're still negotiating those contracts. This is a confidential, voluntary, free program that works to get people who have tested positive for infections connected to treatment that they need. And then we also meet with them to discuss partners and both sex and needle sharing partners, and locate them, notify them, make sure they also get tested and treated. So that's why I have the little map there of the people, because it's not just working with one person, it's figuring out the networks and the connections between infections, so we can try to get as many people taken care of as we can. The real base of our work is building trust with people. We can't just walk on in and say, hi, who have you been having sex with? Who have you been sharing needles with? That's just not how it's going to work. So it's really getting to know people, creating trust, and letting them know that their information will be kept confidential, and also letting them know that it's voluntary. They don't have to tell us everything. That it's their choice. And so that's a big tenet of our work too. And one of the most important things, especially with people as part of the unsheltered, is support without judgment. We're not there to correct anything about their life or change things that they're not ready to change, anything like that. That's not what we're about. And so it's really coming in with that attitude that people are valued where they are at, and we're there for them. And I was going to say, feel free to ask questions if you have them, either in the chat or at the end, we'll answer any questions you have. Okay, so here's kind of the steps of disease intervention. Like I said, we find out that someone has a positive test, like if they have syphilis. We find out about a case through clinics or through MDH. And the first job is to locate them and make sure that they've been treated. And sometimes people have no idea that they tested positive. Like if they tested positive as part of an ER visit, they may have no idea. And so we find people out and about. Some people, it's a phone call. It's really easy. Other people, we really need to do some digging to figure out how we can find them. We notify them of their test result and arrange for their treatment. Once they get treated, we do what's called an interview with everyone, and the interview consists of providing STI education, prevention, transmission education, also really discussing results with people, and so that they know how to look at their own results. Especially with syphilis, that can be kind of tricky, and so we really want to make sure they understand the RPR titer will change, and so when they look online or call in, they would know what's going on with their own infection. Then we discuss partner notification. We offer this service, and sometimes people say, I don't know who they are, and we really talk through how we can help figure out who people are, even if they just have a phone number, even if they just have like a first name. That's part of what we do, is do some digging. Like I wrote the word investigate, that sounds worse than it is, but it's really like digging in to try to find out, where do they live, where do they hang out, to try to weave our way to track down that person. One of the most important things too is once we find a partner, we will never reveal anything about the original patient to that partner. So in some cases, they only have one partner or one person, so they can kind of figure it out on their own who named them. But other people have no idea, and we will never give away dates or places or names or anything like that. So we really build that into our program, and our program would not succeed if we didn't obey that tenet there. So then we notify the partners, which can be tricky sometimes. People always want to know who named them. Again, we don't tell. And try to convince them, they might be like, I have no symptoms, I'm not worried about this, but try to explain why it's important for them also to get tested and possibly treated, depending on when their exposures were. And then we work closely with many different clinics to coordinate follow-up for those partners too. And a lot with Sarah Jane, a lot with Healthcare for the Homeless, to get people in and tested and treated. And part of the responding to the drug-related outbreaks is being out there with Healthcare for the Homeless. We go out in the field with them, meet people, and it's not always that we're talking STIs with people while we're out there. We're talking about everything else. We're handing out safe use supplies, we're handing out snacks, just getting to know people. And then when it comes time that we have to talk about STI stuff, then they already kind of know who we are and they feel a little more comfortable with that. We're a familiar face, so that helps. And the meet unstably housed patients where they're at is that we do go out and we go to shelters, we go out on the street, and meet people anywhere. So there is a group of there are a group of DIs who meet people in the clinic, and that's kind of easy in a way because they just come right from the nurse's office right into the DI office. So that's a little smoother. But part of this effort is getting out of the clinic and being out in the community more. And let's see, this is our work really would not function at all without community partnerships. So I just wanted to highlight the main ones here. You can see, of course, number one, Healthcare for the Homeless, Sarah Jane, and just other community clinics. NACC, Nikki and I are talking very often about cases where she's trying to find someone, we might be trying to get someone into NACC, that kind of thing. So just having that great relationship with community clinics is just super important for our work. Corrections is actually a really strong partnership for us, because when people end up in a jail setting, we can see that and notify the jail clinic, this person needs treatment, or if there's people that we're trying to get screened, they will do that for us. So we can send them messages through our electronic medical record. And it's actually become a really nice partnership with the corrections, housing shelters like Avivo, we work closely with them. It's been amazing to work with different shelter programs, and some have outreach workers that we partner with too. So really important. Of course, mental health, chemical health, harm reduction is all like the base of it too. And we are doing referrals and teaming up with people that are out working with the community there too. So let's see. Oh, now I can hand it off to Sarah Jane. Yeah, thanks.
Great. Yeah, thank you, Judy. And I will just, shine all that gratitude right back at Judy. I was doing a very different job in 2019. And then as the information was coming about infections that were happening in our unsheltered population, I was asked to kind of move back to Healthcare for the Homeless. So first we saw hepatitis A, cases of hepatitis A increase in people who used injection drugs and mostly slept outside. And then it seemed really clear that that network was also really impacted by the HIV outbreak. And I couldn't have done any of this without partnerships with NACC, harm reduction, and then the public health clinic and the disease investigation team. And it's not like I'm doing any of this either. I think the thing that I really want to bring up is that people who use drugs or exchange sex for income, people who are unsheltered, are the ones who are keeping each other safe, healthy, and alive. And so figuring out how we can partner with the care that people are accessing and find meaningful really is what the base of this work has been. So appreciate all the flexibility and partnerships that we've been navigating in the last few years. And also just to recognize that a lot of this coordination has happened during the time of the pandemic. So the HIV outbreak in Hennepin and Ramsey counties was declared on January 9th of 2020. And I think that all of the planning about what our response was going to look like, then when April 2020 came around and everything was shuttered and clinics were, changing care models and outreach meant something totally different, our care really had to pivot as well. The definition has always kind of centered around people who use injection drugs, mostly people who were experiencing unsheltered homelessness, where that was the initial definition. Sex partners or syringe sharing partners of people known to be living with HIV, people who inject drugs and their sex partners or needle equipment sharing, and then folks who were inside of what they call this encampment corridor. And we can advance to the next slide because that will kind of show us that geographic location. And you'll see NACC right on there. So what I think of it as between Franklin and Lake Street along that Bloomington corridor really is the heaviest, where we see the most new cases of HIV that we're screening on an out, like in an outreach capacity. And that a lot has to do with the incidence of encampment clearings. And even just today, I was out this morning and noticed that they're clearing all of the tents underneath Cedar 94. So that was a place that we were meeting really regularly with folks. And that is part of this work, is that our folks really have community, have a geographic location, have connections in this area, and also are chronic unsheltered. So we know that we will find them again if a camp is cleared. And that kind of like creates these different strategies of making sure that the care and the services people are seeking out, that we're able to connect care right then. So as of October 6th, there were 175 HIV cases in Hennepin and Ramsey County. And you can see they also included, and that's also the Duluth area, 121 here in Hennepin County, 28 in Ramsey, and 26 in the Duluth area. I think the other thing about this map that is important is that, in Hennepin County and even within our community that's unsheltered, there are many folks that are experiencing unsheltered homelessness that we may not be interacting with. One thing that happens, I think, sometimes is the idea of homelessness gets kind of flattened. And so we are trying to figure out how we can really express, unique or specific, not necessarily to talk about the risk factors, but really recognizing there are community and like resilience clusters within these different places. And then when we have good connection and coordination and relationships with folks, that really is what drives our response. And we can go to the next slide. I'll talk a little bit about healthcare for the homeless and our drug-related infectious disease response. So, and sometimes when I share about this slide, it sounds really robust. I want you to know that there's just like a little crew of us that's doing this. We have a PrEP pilot project, so low barrier PrEP. And I bring medications to people weekly, about 15 to 20 folks just in there, along with syringe services, snacks, like just our basic outreach stuff that we're rolling around with, and set up weekly medications for folks on PrEP. Several of the folks are syringe and or sex partners to people living with HIV, and really successfally, folks that are taking their PrEP consistently are not seroconverting to HIV. Similarly, we're bringing antiretroviral medications to about 15 to 20 people each week. And that is, making sure that people have access to medications and labs. we noticed kind of early on that people were interested in, like maintaining undetectable and taking HIV medications. However, getting to a clinic, getting the labs, navigating all the systems that you have to navigate in order to do that became, it was just a lot. And so if we were able to like make the medications accessible, people were very willing to take them. And then really focusing on that, what are the fundamental things that have to happen? So labs and medication in order to, achieve undetectable, untransmittable. In addition, Judy mentioned this, I think one of the strategies is making sure that our services aren't going to stigmatize people. So I want people to feel like they can ask me about housing, they can ask me about an infection, they can ask me about their feet, they can ask me about, just to use the phone to call a sibling, so that when people are talking to me, it's not just that they're talking about disease investigation or a sexually transmitted infection or HIV, that really there's a lot of reasons to talk to us when we're out and about. Through those, kind of network and all those relationships over time has kind of like created a panel of people that we really have worked with over time. And that's what has driven some of the partnerships. So with corrections, even with hospital discharge, and then with other community partners to recognize what care people are seeking out. And then that gives us a lot of idea of when there are spikes in different infections. We also, through Healthcare for the Homeless, have a buprenorphine team. And I feel like we've really, learned a lot from NACC, both with our infectious disease response and buprenorphine, doing some microinductions and really looking at how to make sure that MAT, or medication for opioid use disorder, is available for our folks. We can look at the last slide. When I started working as a nurse, I didn't think I would ever be the right person to, really talk about people's veins, talk about needle size, talk about drugs. I'm oftentimes asked questions that I'm like, gosh, I can't believe that I know the answer to this even, but I'm really wanting people to know as much as they can about their veins and about their syringes. I think the gap that we're finding right now for people who use injection drugs and are interacting with our medical care, there's so much stigma and there's so much discrepancy between this idea of like what motivates people to be well and how they know to be well, and then what is recognized when oftentimes they're, in a clinic visit or certainly at the hospital. I would say for most of the folks that are using injection drugs, and especially fentanyl, when they're accessing care at the hospital or any kind of like longer clinic visit, what becomes the scariest is the feeling of withdrawal or lack of pain management, even more than a scary procedure that they might be facing or an infection that they might have, or other things. Like engaging with medical care is always intimidating and scary. And then really to note that oftentimes it's that experience of withdrawal that makes it harder to access. So figuring out how we can, do some of the incremental care along that way so that people have all the different ways in which people can access harm reduction. Yeah. And I think we can advance to the next slide, but I think that's more about our services. So we have the information about Hennepin County Red Door Clinic, or our public health clinic, which is on the 4th floor at 525 Portland. And all of the hours that the clinic is open now offers syringe services. So we have, fully staffed folks that are able to do the harm reduction and syringe services. Also there is syringe collection, which I think is one of the things that also our community is figuring out as we're figuring out how to get more access to syringes. Also, how are we picking up syringes as we're out and about too? And it looks like Judy also put the number for the Minnesota Department of Health if you have any questions about or need to report for sexually transmitted infections. And I think that kind of wraps up our information section of our time together. I know that folks had said that we could put questions in the chat, but I'm really happy, or we're happy to take any questions or responses too. I know there's a lot of folks on the call that have a lot of experience as well.
So of course, if anybody has any questions, of course, then now would be the time to ask them. Sarah Jane, did you also say that you might have a case presentation or just talk through the case with us? What people are thinking about that?
Sure, I'm happy to put some kind of information in the chat I wrote out here.
Good.
So I thought I'd bring up this case to really demonstrate the coordination that happens between disease investigation, healthcare for the homeless, and the Native American Community Clinic. So I'm going to be talking about a 31-year-old female with a history of substance use disorder, uses injection drugs, and has the experience of chronic unsheltered homelessness. Kind of some background information. In December of 2015, she was in the hospital and had a HIV negative test. In 11/16 of 2020, she was seen by our outreach team and had an INSTI test, an HIV INSTI test that was negative. At that time, she reported that she's accessing community-based harm reduction programs and syringe services and safe use supplies. And then in May of 2022, she met with me on outreach and she said, you know, I've been meaning to talk to you. I just got my HIV diagnosis. I haven't told anyone else yet. Kind of curiously, like that same day, that same afternoon, I think that folks from NACC had reached out to Judy to do disease investigation. And so we were able to do some coordination there. She had medications for her at NACC. We were able to coordinate that, you know, kind of on the front end. And then I have some more info to add in just about her, what resulted from that. So I think I want to say at that time, there was also some question around her RPR. But then when we did her labs in late June, she was treated for gonorrhea, chlamydia. She has a low Hep C viral load. And I expect that the next time that we would draw her lab, she may actually clear her Hep C and a very low HIV quant. So that's like the viral load that we look for. And was able to get her genotype completed and really review her symptoms. At that time, she also met with Judy through disease investigation. We were able to do some other partner services. Curiously, she was also named as a partner to someone with syphilis. And that kind of happened within her disease investigation, as I remember it in the interview. She was naming partners, and that a person that had recently been treated for syphilis was one of the partners that she named. So we were able to get her care with that. And then we were able to start her Biktarvy, and she's maintained, you know, like I would say maybe there's some weeks where we haven't been able to do the medication setup just because of sometimes camp clearings or sometimes other like logistical barriers, but really has been taking medications consistently, has connected with NACC, has connected with Indigenous Peoples Task Force, and is, you know, like really accessing medications, and now was recently housed through Claire just in the last week. So wanted to share that story just about how all those parts work, and happy to have other folks chime in. Yeah.
Oh. So thank you for that. I had a couple of questions. So like so it's, well, actually it's more of a comment. It seems like what was really powerful in this for me hearing about it was that there was an existing relationship. So you created a connection. There was a connection with her pre-existing, and you know, around, as you said in your presentation, like, you know, like through like around the community and just being present and helping people with whatever it is that they need help with. And then that created this a bridge for her to ask for help. I think that was what was powerful for me about this case.
I'm curious from a like not so hopeful, optimistic outlook. What do you do? What are some of the things that some of the strategies you use when you can't find somebody? Maybe they've left the area. Yeah, I mean, just I'm curious what you guys do then when it doesn't work out so well.
I can speak. That happens a lot. um, so we definitely use connections with family. And I don't mean to say that we share any information with the family member, but we can leave messages, very generic messages with family members, friends who we might see in their chart or who we know out and about. Just to say, I have some follow-up information. Can you please give me a call? Like that's like all we would say. Also, if they, we have knowledge that they work with a case manager somewhere, we will leave a message with the case manager. If we know they frequent certain places, make the rounds there a lot and try to find them. But it does happen that we won't hear from someone. We won't hear back from someone for months, and then suddenly they pop up, and then we just take it from there. So yeah, sometimes they've left the area. We always check like jail rosters, hospitals, all kind of the typical places like that. But we definitely leave a lot of like very generic messages around for people.
So with the working with the jails and other hospital systems and clinic systems, are you able to do any sort of like, hey, we're looking for this person. If you see them, let us know. Or is it something you guys have to really monitor those rosters or monitor? Can you let Fairview know, hey, if this person shows up, we're looking for them?
Yeah, I would say we monitor a lot of lists. We keep patient lists, and if they happen to go in somewhere, we'll get that'll show up on a list that they're in somewhere. But there is also like a sticky system that we can use within Hennepin. I don't know that it would cross over into, Sarah Jane, maybe you know if it would cross over into the other healthcare systems, but within Hennepin, there is like a little blue sticky. We can leave messages, and we do a lot of inboxing. If I can see, for example, that they have an appointment coming up, even like for physical therapy or something, I can leave a message and say, if the patient shows up, can you please have them call me? And then I can see if they showed for that appointment, or if they didn't, or if there was any interaction on my chart, or anything like that. But as far as notifying, it would I guess the same way. If I can see they have an appointment at Fairview, I could call ahead and say, if they show, can you give them this message? Do you have anything different, Sarah Jane?
Yeah, no, the things so I just want to shout out again to Judy and the disease investigation that's been happening in Hennepin. The Minnesota Department of Health does disease investigation, but isn't embedded in a health record. So that Hennepin County Public Health has that kind of like infrastructure of Epic, and being in the Hennepin County medical record really is a huge advancement as far as coordination in that way. So not that we're necessarily able to send messages directly to Fairview or Alina, but because of that electronic health record, they would see our notes, just like you all, like if you do the Care Everywhere link. So that can be a really huge, and we've had several times where people, have shown up in an emergency department or in another care system, and someone has caught that and gotten treated. That's always like, I want to send them a thank you card from Hennepin County, and then it is a lot of really recognizing that I mean, it goes back to what Dr. Robbie was saying. I think for a while I was hesitant to really like claim a relationship with folks when I was having these brief interactions with them around harm reduction or syringe services. But what has shifted as we've really just like settled into that is like, oh, we actually have this distinct patient panel of folks that are really wanting more coordination when they're in, like when they do access care. And if we're able to link that in a way when they're like in the right place at the right time to get services, that can be really person-centered. And I have a lot of hesitation about, like sharing lists or, putting people on radars or, like people who experience unsheltered homelessness are overly, there's so much surveillance, there's so much displacement, there's a burden of infection, burden of stigma. So I just want to reduce that any time that they're accessing care. And so really making it like, hey, this person's there, can you offer them these services without more background or information, I think has really, I've heard from people that that's been meaningful for them, and recognizing people are able to get treatment. And then I think like the other thing that goes along with this, like, in early 2020, we really had this like kind of like absurd list of 30 names of people that were on the HIV outbreak, right? And we didn't have relationships in a lot of these cases. And in a lot of ways, like really knew, the only thing we knew is that people weren't accessing care and people weren't really like, we didn't have a strategy yet. And so what has really been a game changer is having relationships with people throughout their care, even when a HIV diagnosis happens, like to this point with this person that we talked about, it is really different if I have done HIV testing with them before or seen them out and about than if we're talking about doing labs and getting medications right away. Folks, I think, are much more able and ready to be taking medications and be consistent with it. I'm curious, and this is just anecdotal from the conversations and relationships that I have with folks, for folks who had a diagnosis and didn't have that experience of getting their confirmation labs and getting started on medicine right away, or had a gap in that, or had some time where they weren't, restarting or re-engaging with care is much harder, or seems to have a lot of different barriers. And I don't know, what that means about relationships or clinic or understanding or psychology about what happens when we receive news and then don't have options that feel accessible, and then what that does over time, and then how to shift that. But it makes me really proud of the work that is happening at NACC and is happening with our project, where we just know that that doesn't have to be, there is the option of like finding out that information and getting care and services started right away that is going to build a relationship in a meaningful way for people to be healthy and well. And that really is, I think, what else we have learned. And I'm not a sugarcoater. Like, I mean, I feel like that's what can keep us in this work. Of course, there's like the numbers of people that are out of care right now, living with HIV, experiencing homelessness, are pretty devastating. Do I feel like we're close to ending the HIV outbreak? No, but are we learning and developing services and tools for people who may, who may have HIV? I believe that we are building a better response, if that makes sense. I really usually don't have that kind of like really optimistic, like we're doing great kind of attitude. So I don't know what's coming through here, but I don't want to, yeah.
I think that what we've observed from our vantage point is just that the need to shift how HIV care is provided from base like the of 10, 15 years ago, where you're really dealing with a more a population that's more stable, like just in general and then the group of people that you're reaching out to, Sarah Jane and Judy, there's a history of marginalization and stigmatization that and even within my perceptions, even within the concept of HIV care, those patients were marginalized. So, there's no way to really impact or reach these people, so we're not going to try. And so I think what's exciting to me about this is that I'm watching your work and creating bridges and opportunities and showing that it can be done. It is a worthwhile effort for so many reasons, and that it can be also be successful. I think that is the optimism that I'm hearing.
Yeah, I mean, it is really incredible. People that we work with, so there's a few of these cases where they had a negative HIV test, and within a couple of months had a positive HIV test, started on medications, and in the last 2 years have been unsheltered, using drugs daily, like chaotic drug use, heavy fentanyl, have maintained undetectable, untransmittable over 2 years.
Wow.
I mean, that's amazing. People have been housed and unhoused during that time, have been incarcerated, have been hospitalized, but throughout that whole time are maintaining undetectable, untransmittable. So that isn't a confusion or like curiosity anymore about if people have access to medications, will they take it? Yes, they will. And then what are we doing to like create ways in which that can be possible? And then, yeah, like outside of that, then it's like, what are all the systems, how is it that I work really closely with Tina Armstrong, who is amazing at getting people housed. When we look at folks that are involved in the outbreak and coming out of the unsheltered experience, so many have had a lease and been housed, and within 90 days are exited, or, like that kind of thing. So we know that's outside of even our healthcare models or like these kind of other things. And so grateful that we get to have relationships with people throughout that continuum so that their access to care isn't contingent on, those other experiences.
And it seems like it's really about the connections.
I was gonna say, yeah, I love how you talked about establishing the relationships beforehand, right? Like these relationships and these connections are made, well before a diagnosis, if a diagnosis ever happens, right? And people don't necessarily just come see you or talk to you for, DIS stuff, kind of the same way that we want to establish relationships with patients who could potentially want MAT, right? I don't want to just talk to the patients who want a prescription for Suboxone, right? I want to develop that relationship well before, and maybe they don't ever want it, but that's okay.
Yes. Yep.
I was thinking about that because yesterday we were outside and handing out, sometimes I'm out there and there isn't like a specific person that I'm looking for. So I'm kind of like, okay, wait, what am I doing out here? But then, we're handing out snacks and I just can have a chance to pull the person aside and be like, just so you know, if you ever want STI testing or HIV, you can talk to us about that. And we can arrange that. And then it almost always turns into a conversation. And so it becomes like an educational moment at least. And then you never know, like a few weeks down the road, they might say, oh, I thought about that and I would like to, or I noticed a symptom or something like that. So it's definitely just like slowly building that relationship.
It's powerful.
I did just want to talk specifically about one event so there's a new community-based infectious disease team through Hennepin County, and they started just before monkeypox and have been doing a lot of monkeypox response. But in late July, they did a pop-up to screen for syphilis, hepatitis C, HIV, and all the labs that we would need to start people on PrEP. There were 15 people that accessed it. It was poorly advertised, just kind of like fly by the seat of our pants, 25th in Chicago, like in the alley, kind of close to an encampment at the time. So we were able to like go and let some folks know, and people made their way over the 6 blocks. Screening 15 people in a day is huge. One person from that event, was screened for syphilis at that time. anyone that accessed screening, like swabs or urine screening for STI was positive or needed some sort of response, whether it was trich, gonorrhea, chlamydia. And we also are screening a lot for infections of the throat for sexually transmitted infections. I'm bringing this up because on that date, we had one person that was screened positive for syphilis. Since that time in late July, 3 more of the individuals that accessed that screening event have now been either named partners for people with syphilis or have now had a positive syphilis. I think that there's been some conversation that there's so much syphilis happening and we were behind during COVID in screening and we haven't had, and I just want to be really clear that in our community, we're seeing current active transmission at a pretty high rate. Again, a number of 15 people one day, and it kind of like a, we did have incentives. So people were excited about a $20 gift card for a lap draw. I will say that people were, there was that incentive that was there. But to know that of those folks in that short amount of time now are needing, of the 15, now it's, 4 or 5 folks that are needing response just for syphilis is pretty amazing to me. And I think that those sorts of stories we can keep telling with these different screening events that we're seeing, and we'll see that in clinics and other places too.
Syphilis is really quite something right now. So any other questions or comments? I mean, this is, I really enjoyed this. It's nice to see and hear firsthand or secondhand, I guess, the work that you all are doing. We know that that connection for us is very valuable. But it's nice to hear it in this group. Does anybody else have any last questions or comments before we close out?
You can put them in the chat or use the hand raise function, or just start talking.
I did notice that Mo had a comment. What a great outcome of using and collaborating with various organizations to get the proper care both medically and socially in-house. Great collaborative work. Thank you, Mo. Okay, well, what is our next echo then, please?
Next echo is going to be November 16th with Simone Megas-Harmison. She's from here at NACC, and she's going to be talking about crisis de-escalation. So please join us again. Thank you, everyone.
Thank you again, Sarah, Jane, Judy.
Thanks, everybody.
Thank you. This is great.
Thank you all.